On this edition of Being Well, hand surgeon Patrick Stewart from Southern Illinois Hand Center in Effingham will be our guest. We'll be talking about common hand issues such as tendonitis, arthritis, and carpal tunnel syndrome. Dr. Stewart will address the causes and treatment options. We'll also learn if all that texting and video gaming is really doing us harm. Stay tuned for another informative edition of Being Well. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Dr. Ruben Boyajian, located at 904 Medical Park Drive in Effingham, specializing in breast care, surgical oncology, as well as general and laparoscopic surgery. More information online or at 347-2255. Rediscover Paris. Our patient care and investments in medical technology show our ongoing commitment to the communities of East Central Illinois. Paris Community Hospital Family Medical Center. HSHS St. Anthony's Memorial Hospital, delivering healthcare close to home. From advanced surgical techniques and testing to convenient care for your family, HSHS St. Anthony's makes a difference each and every day. St. Anthony's, where you come first. Thanks for joining us for today's edition of Being Well, and I have a guest in the studio, brand new to the show, Dr. Patrick Stewart, who is a hand surgeon from Effingham. Thanks for coming up today.
Thank you for having me.
Well, tell us a little bit, how does one become a hand surgeon?
Well, for me, it was a rather fortuitous experience. I was in medical school, and I was doing some special research projects interested in orthopedics and in surgery, and the chairman of the department actually came down to the gross anatomy lab, and it was a Saturday morning. Of course, nobody else was there, and I was very impressed because he knew my name, and he said, "Come with me." And so we walked out of the anatomy lab, we went upstairs, and he walked out of the building, and I was a little puzzled, and I followed him, and he walked to his car, and sort of ushers me to get in, and I asked Dr. Watson, where are we headed? He said, "We're going to the zoo." I thought, well, that's really nice. I said, but I have some work I need to do. And he said, no. There was one of their gorillas had fractured their hand.
Okay.
And they did not have an orthopedic surgeon on site at the zoo, so they could do the anesthesia, but couldn't necessarily do the surgery. So we went over and actually operated on a gorilla's hand. And the interesting part was we put a plate that we'd put on one of our forearm bones in the bone in his hand to stabilize it, because obviously he was not going to follow post-op instructions, wasn't going to leave a cast on or anything like that. And so that really opened the door. And the chairman, being a hand surgeon, then sort of explored that, and that's where I ended up years later.
Your first patient was a gorilla.
Yes.
All right.
Did very well. So.
Okay. So as a hand surgeon, what kinds of cases or issues are you treating?
We have, when I came to practice here, I joined Dr. Nam, who's also a hand surgeon. We've subsequently added another hand surgeon, and we've limited our practice really to the hand, wrist, and up to the elbow. Our newest partner does some shoulder arthroscopy and work, but we really concentrate on hand function, hand injuries. There are tendon problems, arthritis problems, ligament problems, and there's just such a wide, diverse array of issues that can occur, and because of the complexity, we've decided to really limit our practice to just those areas.
All right. So we're talking today about, we're going to be getting into all sorts of issues, but it all kind of falls under a big topic called compression neuropathy. It makes me sound so smart when I say that. Explain what that is and what kinds of issues fall under that umbrella term.
Neuropathy is a generalized term that's used to describe nerve dysfunction. So it's not functioning, acting the way it's supposed to. That can be in the form of loss of sensation, numbness, tingling. It can be in the form of not having as much strength in that nerve distribution. For hand surgeons, the most common compression neuropathy is referred to as carpal tunnel, and that is the median nerve being compressed in the wrist underneath the transverse carpal ligament.
I'm going to hold up the hand. Explain, I'm going to hold it while you point out where when you're dealing with carpal tunnel, where exactly in the hand is that occurring?
So the long blue rubber band here represents one of the flexor tendons. So we have 2 flexor tendons to each of our fingers usually, sometimes only one to the small finger, and then one to the thumb. Those go through this tunnel, which is right here.
Okay.
The ligament runs from sort of this bony structure across to these bony structures. So that's the reason that we can get into trouble, is that 3 sides of the tunnel are surrounded by bone. Bone doesn't expand really well without breaking, and the ligament is sort of a thick canvas layer. So it serves as a protective function, but if it gets thickened, if there's increased pressure, it has limited ability to expand or bow, and therefore then we develop pressure. The tendons deal with pressure a lot better or easily than the nerves do. The nerves are an extension of our brain. Our brain doesn't like increased pressure. And when it gets it, it then tells us about it. And most commonly the way we'll tell patients is at night they may wake up and they may have some numbness and tingling in their fingers. That can occur commonly because of sleeping position. We always talk to patients about if they're like sort of this. Huggers and they crank their wrist down, the farther we flex our wrist down, the more pressure we put on that nerve. So it's one thing to do it for 5 minutes while you're doing an activity. It's a very different thing to do it for 2 or 3 hours while you're sleeping. And that's oftentimes why people wake up. Similarly, if they have an extended position of their wrist, they're putting more tension or pressure on that nerve.
Okay. So we tend to think of people who get carpal tunnel, a lot of people who do a lot of computer work. Is that the typical culprit or cause of carpal tunnel syndrome?
It actually is not.
Okay.
There's a common belief that has occurred, and they've looked at this over time because it's important. It's important to know what does and what doesn't put us at an increased risk. And the activities that do are forceful and repetitive. So data entry in and of itself is not forceful. Now that we've gotten to the point where most of the workstations, the computer desks are more ergonomic, they put our hands in a reasonable position, that has not been as much of an issue. Now, I've had a patient, and I'll tell people that that's my opinion. Sometimes they don't necessarily like that. I said, well, have you ever had a patient that you said their data entry wasn't? And I did, but it was a rather unique situation. This was somebody who did monitoring and did quality assurance in a factory, and they were having to monitor parts and they would have to enter data. Well, they happened to keep knocking their keyboard off out in the factory and it would break. And their supervisor got upset with that, didn't want to keep replacing it, so they literally screwed the keyboard to the wall.
Oh,
so this person had to sit like this.
Oh yeah, that's bad.
And that was not good. And they subsequently developed carpal tunnel from that. But running a jackhammer, where you have a forceful, repetitive activity, but also vibration is really a problem, and cold exposure. Okay,
so construction jobs and jackhammering and
yes.
Why is cold a factor?
It's actually, that was discovered actually through primarily the forestry industry and meat packers.
Okay.
And there's a very, very high incidence, and it's the cold that adds to it, because you can take people who do similar things but are not necessarily doing it in a refrigerated environment. And we're not talking about air conditioning, obviously. We're talking about cold enough that it preserves the meat, and they have a much higher incidence of developing carpal tunnel.
All right. So what are some of the symptoms of carpal tunnel? What does it feel like?
Most commonly, it will be numbness and tingling. Some will say it's a buzzing sensation.
Okay.
Some say it feels like pins and needles. It can then become more annoying or become burning, or what we call dysesthesias. That usually will happen again at night, but it can happen for prolonged activities. One of the things is driving. Patients will commonly come in and say, boy, I'm driving down the road, I have to take my hands down off the wheel, sort of shake them out, and put them back up on the wheel. So a prolonged activity is something where that'll bring those symptoms out. If it gets farther down the road, you can have problems manipulating small items.
Okay.
I'll ask patients, or I'll put something on the desk and I'll say, pick that up. And oftentimes, if they've gotten to the point where they're having those difficulties, they'll actually take those, scoop them into the other hand, because they can't pick them up with their fingertips. They can't put their hand in their pocket and identify a quarter versus a nickel.
Really?
Because just they've lost that sensibility. Farther down the line, most commonly, is then we lose motor, so we lose some strength. And for carpal tunnel, it's the movement of the thumb, where what makes us different than that gorilla, my first patient, is the ability to oppose our thumb, to bring it out of the plane of the hand so we can grasp things. The simians can only do this.
Oh, I didn't know that.
So by our being able to do that involves this muscle here, which is innervated by the carpal tunnel nerve, the median nerve. And we have some patients that will come in that have had it for so long that is gone. It's completely flat and they cannot elevate their thumb.
Okay.
That then requires a more complex surgery to reconstruct that ability, doing a tendon transfer for that patient.
So what point should someone see their doctor, and then can you obviously don't do surgery right away.
Right.
But when should someone see their doctor about this?
Well, if they're having just nighttime symptoms, a reasonable place to start is starting with just cockapra splints. And that's something that can be purchased at any one of the pharmacies.
Okay.
And it's just designed to hold your wrist in a neutral position, sort of relatively straight, maybe a little bit of extension, and that prevents you from sleeping in that funny position.
Okay.
If that doesn't resolve it, then you should be, because what we don't want to do is sort of misdiagnose and let something be farther down the road.
Okay.
Because there are other things that can cause numbness and tingling in the hands that we don't want to ignore or push down the road as far as diagnosis.
Okay. So when you do have to go in and do surgery, what are you doing?
We're actually releasing that ligament that
Okay.
goes over the top of the nerve and those tendons. And so I always describe it as this is sort of a flat-topped room. And what we're doing is we're going in and releasing that ligament, and when there's pressure and we release that, what happens is it pulls back and elevates. By doing that, we've taken the flat-top roof and we've given it a pitch.
Okay.
And so we've increased the volume of the tunnel and taken the pressure off the nerve.
All right. So where do you do an incision in at?
For carpal tunnel, if we're doing a standard carpal tunnel release, and this is done very differently depending on your training. Years ago, people would make an incision, and it could be an incision from there to there to release the median nerve.
Okay.
As the anatomy and technology has gotten us better, that we've been able to shorten that incision. So a standard carpal tunnel incision will oftentimes be here. I do mine endoscopically, so I was trained from the beginning. So I make a small incision here. I like that from the fact that
I'm trying to show it at the camera. My wrist does not bend that way. I'll go like this.
There we go. Because by making an endoscopic incision, I don't have an incision on the palm of the hand. If patients are going to have difficulty after carpal tunnel, most commonly it's tenderness across here, especially with loading. I think that's decreased by not having the incision there.
Okay. So a 1 centimeter incision sounds like a much better deal than a big thing right here. So what's the recovery like if you have that?
For our patients, again, this has changed dramatically. They used to cast patients or splint them, and they would be off and not do anything for 6 or 8 weeks. We put them in a soft dressing, so their fingers are free. They don't have any splint. They can move. I tell them to use their hand as they're comfortable. I said if it's a little bit of discomfort, it's okay. Shouldn't be in pain to do anything. They're not going to undo what I did at surgery by releasing it, but they can make it sore. They could cause some additional bruising, so we don't want them to go out and get crazy. But a week after surgery, we change them over to a Band-Aid.
Wow.
At 2 weeks, we take the one stitch out. There's one suture, and then I allow patients to progress back. Most patients are back to regular activities, regardless if it's jackhammering or working in an office or taking care of their kids at 4 weeks.
That's not
no
bad.
restrictions.
So once you have that surgery, can you get this carpal tunnel back?
You can. The published data says 5 to 10% at 10 years. I think that personally is high. I've been in practice now for over 16 years, and I'm not redoing 5 or 10% of my patients, and I've been doing it for more than 10 years. So I think that's a bit high, and that's returning back to the activities that may have put them at that increased risk. Now, the one caveat I always tell patients is vibration. Vibration also puts you at an increased risk, but it's also something that nerves in general do not like. And it's the reason that if we run a weed eater, after a few minutes, your nerves are like, you feel a little numb because they're telling you, put that down, it's vibrating. Well, you finish the yard because you have to, and then you sit it down, and your hands may be numb for 5 or 10 minutes. Patients who have had carpal tunnel and vibration has been a significant component of that, if they go back and they have to run a palm sander or a grinder or something like that, I'll tell them that oftentimes your numbness and tingling will come back after you use that implement, and it may last for a day.
Okay, it kind of hangs out for a while.
Yeah, it doesn't mean that the carpal tunnel or the pressure is back, but the nerve is sensitized to that particular aggravating factor. And so I have some patients where they do that all week, and so essentially their hands are numb all week, but sometime on Saturday the numbness is gone, and then they're able to enjoy their weekend, but they know, because that's their job, that they have to, but their carpal tunnel is not back. Okay.
There was another term that came up in my research, and this cubital tunnel. What's the difference between carpal and cubital? Am I saying it right?
You are.
Okay.
This is the second most common compression neuropathy, and this is of the ulnar nerve. So first, it's a different nerve, and it's obviously in a different place. The median nerve, carpal tunnel we were talking about, can be compressed here. The median nerve can also be compressed in more of the proximal forearm under a muscle. Much, much less common. The ulnar nerve is sort of the opposite. The ulnar nerve can be compressed here at the elbow, at the funny bone, as everybody refers to it.
Yes, that's when you hit that and get that weird sensation.
That sensation is the signal going down the nerve, because it's actually the nerve that you're hitting or contusing that's giving you that funny bone feeling. So that nerve is at the elbow. It can be compressed at the wrist, sort of right next to the carpal tunnel. Much less common for it to be compressed there.
Okay. We often hear, carpal tunnel, cubital tunnel. We also hear about things like tendonitis. First of all, what's tendonitis in general?
Tendonitis is when you do an activity, we go and we lift weights. We get sore because we've lifted more than the muscles were really capable of lifting at that point, but then we allow them to recover and we're stronger. It's when we overload and we cause some of that soreness, specifically within a tendon, then we don't have enough time for full recovery.
Okay.
And so it then feeds upon itself and it's inflammation. So it causes discomfort in movement of that tendon. The most common tendonitis we see are down in the hands, like in the wrist. Tennis elbow
is tendonitis.
Is called tendonitis. It's more of a tendinosis, and it's a fine line, but there's not inflammation. There's more degeneration. There's more a loss of the adherence of that tendon or ligament to the bone that's become the issue. So for golfer's elbow, tennis elbow, it's a little bit different. Treated similarly as far as rest and allowing for that recovery.
Okay. What kind of activities cause tendonitis in the hands and the wrist area that you see?
It can be repetitive activities. One of the things that is a common tendonitis that we see are tenosynovitis, similar when there's a sheath that it goes through and that gets inflamed, we refer to it that way, is de Quervain's, which is along the radial side of the wrist, sort of just beneath the thumb.
Yeah, this thing right here, right? Okay.
Can get painful and patients will have discomfort with use. Now, one of the areas that I see it commonly occur is after a new baby. It's funny because you'll see whether it's grandma, the new mom, sometimes a nanny or babysitter, because they're grabbing and scooping the child. And I say to patients, they come in and I'll ask a grandmother, I said, new grandbaby, and she'll look at me.
They just know.
And they just know. And so that is inflammation around two of the tendons that go to the thumb, and it goes through a little compartment. So our tendons, if we think about them similar to a string on a bow, they need to be held in a particular place or they'll want to pull away. They'll want to go between the two ends of the bow. So if we don't have a sheath or we don't have a tunnel for them to go through, they won't be as functional. So it goes through a tunnel. If that tunnel gets too tight, then it's painful to pull the tendon through it. That we can treat conservatively most commonly with just an injection and then a short period of mobilization. Okay. And it goes away.
So what kind of, is it an anti-inflammatory injection?
Yeah, it's a steroid.
Okay.
So it is a cousin of prednisone, but the steroids have lots of different effects. People hear steroids and think, oh my gosh. One, we're very fortunate in that we're not injecting into a muscle and we're not injecting it into a vein, so the body doesn't see all the medicine. So people are worried about, and rightfully so, the effects of steroids when they take them by mouth for a long time or they get lots of injections in muscles and things, because there it's being absorbed and your whole body's seeing it. In this case, there's a limited amount that your body's seeing, and so we're getting maximum benefit by putting the maximum amount of medicine where the problem is and limiting the side effects by not being absorbed fully.
Okay, so before you call your local hand surgeon for your tendonitis, are there some things you can try at home first?
You can try an anti-inflammatory. Aleve and ibuprofen are very good. I think it's interesting, there's new warnings out based on the cardiovascular and stroke risk, and this sort of came out of the Celebrex, Bextra, Vioxx, which were medications that came out that were tolerated very well from the standpoint of the stomach, but did have an increased risk. Well, essentially all the non-steroidal anti-inflammatories have that risk. So you have to be careful because these are over-the-counter medications. But you can try that, and I always tell patients, if you're going to take a medication, take it like you mean it, meaning take it at the prescribed dosing and on the prescribed level. Tylenol is a pain medicine. So you take it if you have a headache, it sort of blocks the pain, doesn't treat the underlying cause. The anti-inflammatories like Aleve and ibuprofen are designed to take down inflammation. But for ibuprofen, you have to take it 3 times a day. For Aleve, you have to take it twice a day. If you take it less than that, then we get the medicine going up in our bloodstream, the inflammation going down, and then as the medicine goes down, we can sort of pinball back and forth.
Yeah, it doesn't really do what it's supposed to do.
And so I tell patients, take it for 5 or 6 days on a scheduled basis, even if you feel better after 2 or 3 days, to really knock that inflammation down.
Yeah. Okay. So I have to ask, are you getting a lot of people, we're a texting world and video gaming, are you getting people coming in with issues with their texting thumbs or, anything like that?
I think we're seeing more aggravation as far as thumb arthritis.
Okay.
Because the thumb is also based on the way it's built and the way it's designed. It's a lever, and so there's actually an increase in the amount of weight. So if we push with 1 pound of pressure at our thumb tip, it's 3 pounds back at the basilar thumb joint. That is one of the most common places that patients can develop arthritis, because our thumb does essentially 4 times the work of the rest of the hand, because it opposes the other 4 fingers.
Right.
So patients, as we get older, my age and older, will start to develop discomfort in the thumb because it's been doing so much work, but it's also because it's sort of a at-risk joint. It's a very supple and sloppy joint from the standpoint that it can do so many things. It can move in all planes, round in circles, whereas a lot of our other joints are more diarthrotal. They can only sort of move up and down, and they have limited motion otherwise. By having all that motion, it's a little bit too sloppy, and so the bones can slide inappropriately and wear out to some degree.
So you had talked about you're seeing something called trigger finger, which isn't necessarily someone that is firing a weapon a lot.
Correct.
What is trigger finger?
And trigger finger is a condition where the tendons don't want to glide through that tunnel that we talked about. In this case, it's on the palm side of the hand. So rather than the top side we were talking about, Dequerre veins, it's on the palm side, and so they may either have a difficulty getting their hand into a full fist, or if they get it down in a fist, all the fingers may come up but one, and it's sort of stuck. Sometimes they have to actually pull it to pop it loose. Other times they're able to sort of force it open. That's usually from a little bit of swelling within one of the tendons, most commonly the sublimis tendon. We as talked about before, we have 2 tendons to each of our digits, and if that gets a little bit full, the tendon and the tunnel have essentially 0 tolerance. They are perfectly matched as far as size. So if we get a little swelling, somebody's not happy. And so it will have a tendency to not want to glide as easily, so they have a hard time getting it down. But if that little bit of swelling gets down and gets outside the tunnel, now it doesn't want to go back in.
Oh, so that's where you gotta go.
Yep.
Push it open or in. Yeah. What's causing that trigger finger? What kinds of activities?
It's something that most commonly is idiopathic. A lot of these we have different characteristics of the person that can put us at increased risk. So if you're a diabetic, you have an increased risk for developing trigger fingers, different tendonitis, and carpal tunnel. If you have rheumatoid arthritis, that's also the same. Any kind of autoimmune inflammatory condition, so lupus, psoriasis, rheumatoid arthritis, those all put you at increased risk. Activities, if you are really doing a lot of repetitive activities, and I think part of the reason, this is again a little bit of a design defect, but the original architect's not available for comment. It is because of the angle that the tendon has to take as we bend our fingers, because that first part of that tunnel is right at a joint. And so if you can imagine, the tendon is traveling parallel to your hand, and then all of a sudden your fingers come up at a 90 degree. Well, that tendon is taking that 90-degree turn and can rub on the front side of that. So if ultimately we have to do a surgery, all we do is we move that point of transition out about 1 centimeter to 1.5 centimeters, and it resolves the problem.
Okay. You wanted me to ask you about CMC arthritis.
Yes, that was one of the things I alluded to as far as the texting or different activities, and this little guy is demonstrating lots of different joint replacements. So these are all silicone joints that have been used, but this little blue cylinder here at the bottom is one. We don't necessarily use this anymore, but this represents the CMC joint, and it's where the thumb comes in contact with the wrist.
Okay.
And that's the joint that again is at most risk for those when we are grasping and doing different activities because of the increased load, and because it's got that variability and circumduction moving in a circle up down, it can slide in and out, and when it does that, it starts to wear inappropriately on the cartilage. When we have perfectly healthy, perfectly matched cartilage, there's less friction between the cartilage than there is between 2 pieces of ice sliding across one another.
Wow.
So when it's healthy and perfect, it is wonderful. When it starts to go south, then we have to intervene.
So is excessive texting or video gaming bad for our
joints in our hands?
It is, because it has a limited load, we're not seeing a dramatic problem as far as that's concerned. If you have an underlying problem, I think it can exacerbate or aggravate it, yes.
All right. Well, Dr. Stewart, our time is up. Thank you so much. Who would have thought that this little hand could be so complicated and it's a perfect, well, it's an imperfect design and we use it so much and it can come with some problems. So thank you for coming to Being Well today and telling us all about what hand surgeons do and the kinds of things you use to make us better.
Well, thank you very much. Thank you for having me, and I hope the viewers were happy to learn some things, and if there's any questions, they certainly can contact their physician and find out more.
All right. Thanks, Dr. Stewart.
Thank you.
Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Dr. Ruben Boyajian, located at 904 Medical Park Drive in Effingham, specializing in breast care, surgical oncology, as well as general and laparoscopic surgery. More information online or at 347-2255. Rediscover Paris. Our patient care and investments in medical technology show our ongoing commitment to the communities of East Central Illinois. Paris Community Hospital Family Medical Center. HSHS St. Anthony's Memorial Hospital, delivering healthcare close to home. From advanced surgical techniques and testing to convenient care for your family, HSHS St. Anthony's makes a difference each and every day. St. Anthony's, where you come first.